Welcome to HL7 Da Vinci Community Roundtable. Today's session is Risk Adjustment, Reporting at the Point of Care. My name is Alex Goss, and it is my pleasure to moderate today's Community Roundtable and to remind all of us that we engage in these forums under HL7 antitrust policies and to ensure appropriate collaboration and information sharing. We're grateful for your participation in the June Community Roundtable, Da Vinci's monthly educational webinar. Today's agenda starts with just a few program updates before our implementation presentation. This month's implementation journey showcases how the Da Vinci Risk Adjustment Implementation Guide, or IG, supports exchange of risk adjustment gap reports at the point of care. In the discussion of one of the newest Da Vinci use cases, our presenters will show how standard protocols, which are payer agnostic, enable communication of chronic conditions and simplified workflows. Presenters will also illustrate how providers gain the ability to share real-time feedback and clinical evidence to address gaps. An overview of the implementation guide and a question and answer period will conclude the webinar. Today's presenters include Josh Lamb, Integration Architect at Optum, Linda Michaelsen, Director of Healthcare Interoperability Standards at Optum, and Nidhi Pengoria, Senior Product Manager at athenahealth. We've included time to take audience questions at several points in the webinar, so please use the question function in the GoToWebinar panels throughout today's event to submit your questions. So let's go ahead and take care of some housekeeping. We'll post the recording of today's webinar and slides on Da Vinci video presentation page on Confluence. Da Vinci's communication lead, Leslie Amoros, will be posting links in the chat box to assist you in locating pages and other resources you may find of interest. We have muted the lines to aid the quality of our recording today. Should you encounter audio issues, we suggest rejoining the webinar or obtaining audio by dialing in using the number provided in your registration. Finally, we appreciate your survey feedback, which we will solicit at the conclusion of the webinar. Community Roundtable schedule is typically the fourth Wednesday of every month. However, we will be taking a hiatus in July, and we will start back up again in August. August 23rd will be our next meeting. You can certainly find past events and recordings on our video page. In regards to the upcoming events, I'd like to tout today 4 different ones. First one is the CMS holding their usual testing event, or a Connect-a-thon. It is next month, July 18th through the 20th, from 9 to 5 p.m. virtually each day. It is a free event, as I noted, it is virtual, and it is CMS's 4th annual Connect-a-thon. Registration closes this Friday, June 30th, so we encourage you to go ahead and sign up if you haven't already, so that you can join developers, programmers, technology experts, analysts, and CMS colleagues to learn about and test emerging fast healthcare interoperability resources, or FHIR APIs, and the supporting FHIR implementation guide. Also this summer, WEDI, the Workgroup for Electronic Data Interchange, is holding their summer forum. This is a hybrid event the first week of August, and you can attend the meetings in Chicago or attend virtually. The 2023 Summer Forum will be 2 days of education and discussion around several core topics: adopting technology and automation solutions to simplify prior authorization and attachments, business strategies for implementing new prior authorization and attachment processes to improve efficiency and reduce administrative burden. And finally, the regulatory and policy considerations related to prior auth and attachments. Let's transition to the HL7 related events. The first one I'd like to tout is HL7's Fire Security Educational Event, August 8th and 9th. The agenda was just posted this week, and with an outstanding lineup of speakers. The cost of this virtual event is $99 for HL7 members and $199 for non-members. Just as applications, networks, and servers can be subject to attacks, APIs can fall victim to a number of different threats. The HL7 Fire Standard offers implementation guidance and innovative tools to ensure your web-based data sharing mitigates cybersecurity risks. So you may be wondering how you can participate. There is a general track for non-technical people who are looking for a foundational approach to fire API security. And there's a second track for the developer community, for those who are with technical experience, as the event offers them advanced hands-on fire API security tutorials. The agenda includes an overview of the basics of API security and practical introduction to the tools that test those APIs for common vulnerabilities. It also is an opportunity to learn about the motivation behind SMART and take a tour of the core components, focusing on SMART's ability to support both clinician and consumer-facing apps. You can also discover how the HL7 UDAP Security Implementation Guide layers extensions to OAuth and OpenID Connect standards onto the FHIR standard that, together with the public key infrastructure, allows FHIR to be securely scaled. For the developer track, you can also apply your skills in FHIR security tutorials and deep dive sessions to really help you implement FHIR. The final event I would like to tout is the HL7 Connect-a-thon that's coming up, along with our 37th annual plenary and working group meeting. This is slated for September 9th through the 15th in Phoenix, Arizona, and it will be in person, and early bird rates will be available through August 18th, and we'll fill you in on more of those details at our upcoming community roundtables. Let's give some program updates. This month is going to be a little light. We really want to provide enough time for our presenters today, including their implementation guide walkthrough. So I'm going to hit the key items. For many of you may be aware, others may not, that in 2023, the Da Vinci Project is expanding its membership with a revised fee structure. Please consider joining if you're interested in influencing, creating, and implementing standards that enable efficient, value-based care information exchanges. In particular, we're focused on adding the voices and experiences from small and community-based providers, regional, Medicaid, CHIP, and other health plans on the exchange, along with missing integration partners. Please consider this opportunity and reach out to the Da Vinci PMO, and we're appreciative of those who've already reached out and are working through those emails. The 2023 Da Vinci Implementation Guide Roadmap provides an overview of the discrete IG or implementation guide work and related ballot cycles, and can assist you in your resource planning, whether human or financial, to ensure your organization and teammates have the knowledge, tools, and context to advance interoperable and efficient information exchange as a part of achieving your organization's mission. I'm going to cover some updates on this slide, but I also have them summarized on the next slide. The key updates that I'd like to provide, and we just updated this as of June 19th, thanks to the support of my teammates, Crystal Calum and Jocelyn Keegan. The expected publications for a few items have changed, and we're expecting some shifts, particularly in the burden reduction publication timing. You'll see the delays are signified by a plus mark on the legend, and affects not only the expected publication in June, but also expected publication of PDEX. So first, let's talk about burden reduction. They are having a lot of very active discussions to resolve the ballot feedback. If you aren't attending these calls, then you're missing out on some juicy problem solving and design discussions. As a part of the reconciliation process, the team will not only figure out the design aspects that they need to account for in the final publication, but they're also going to have to make a choice on publishing all of the implementation guides at once because of the interdependencies across the three guides, or to publish each IG when it's ready to go. So we're really talking about the burden reduction trifecta of coverage requirements discovery, documentation, templates, and rules, and prior authorization support when I talk about the burden reduction 3. Also in the expected publication this month, sliding into next month, attribution member attribution. They're working on the final tickets through their sponsoring work group right now so that they can get the ballot package finalized and moved through to the publication process. So that one should come out of the process fairly soon. For payer data exchange, or PDEX, this is taking us a little longer than we expected to publish, but we are expecting it to be out by mid-July, well before the Connectathon. The Data Exchange for Quality Measurement Group is also wrapping up their ballot reconciliation, and their reconciliation package has been uploaded to the ballot desktop processes, and requests for negative votes have been sent out. I should clarify, negative vote withdrawals were also sent out. The work group quality assurance review and publication request will likely start in the next week or two, and then it will go forward through the approval process for publication. That was a lot of information that I've also provided in shorthand on this slide so that when I post the slides tomorrow, along with the recording, you can pick up those details and share them with your teammates as necessary. In regards to the July Connectathon, I want to remind and encourage all of you yet again to come join, learn, and contribute, and to also to point out a few educational sessions. So this slide provides you with the core details on the event and where to register, and also provides you with a link to the agenda and testing tracks, as well as some resources to help you get ready should you still be looking to learn about what it takes to participate in a Connectathon from a testing perspective. But let's focus more on this slide, which is the Da Vinci, it provides on the left, the Da Vinci tracks. We will have burden reduction, CDEX, clinical data exchange, patient cost transparency, and payer data exchange will be tested. These 4 tracks also have had their corresponding kickoffs in the last week or so, and they will be having ongoing touch bases between now and the actual Connectathon when it launches on the 18th. You can find out more details by using the link at the top of the screen to go into the track breakout details and notes sections of Confluence. On the right-hand side, I wanted to tease out the educational tracks that you might find of interest, because I think that unlike other Connectathons, the CMS Connectathon provides an amazing amount of content across the FHIR accelerators, but also the policy aspects from various federal agencies. And they're very extensive on day 1. You will hear updates from the Office of Burden Reduction and Health Informatics. You'll hear from CMS's Health Informatics Officer, Centers for Clinical Standards and Quality, CMS Innovation, an Emerging Innovation Group update on Medicare fee-for-service requirements related to their modernization projects. You'll hear from State Medicaid Interoperability Endpoint Directory, Blue Button 2.0, Advanced Explanation of Benefit Rulemaking and Implementation, Social Determinants of Health from CMS Office of Minority Health, and of course, we'll hear from CMS ONC as well. Lots of really action-packed updates I would expect on that first day, and then it's followed by a variety of learning opportunities in the afternoon. On day 2, they bring some more additional educational opportunities through hands-on sessions that provide demos and testing, but also implementation guide overviews and office hours peppered with a few presentations throughout the day. On day 3, this is really helps us continue with the testing that we've focused on in day 2, and also brings a variety of track highlights as well as office hours and report outs on the Connectathon testing efforts. We hope you'll join us, learn, and think about how in the future you can become a tester and participate with the rest of us. The Da Vinci Project has launched an implementation chart for all of industry to use, not just the Da Vinci membership. We invite everyone to share your API implementation progress with deploying Da Vinci use case specifications, whether you're in development, testing, or production. By sharing this information, you can help the Da Vinci leadership better understand the traction we're getting in the marketplace, as well as helping your peers and colleagues understand where you are in your development of the APIs, and that provides an opportunity for wider collaboration among the community. and to understand the landscape of API adoption. We hope you will come in and update and edit this implementation Da Vinci in Action interactive page with your project information. And to help round us out and wanted to provide a listing of all of our standing use case calls, I did showcase some of the publication status, but there's a lot of work happening every week across our use case that are listed on this page and the corresponding meeting times. There's also reference information on how to sign up for the conference calls and as well as the listserv messages. I checked quickly to see if we had any questions at this point. I'll remind you that you can certainly submit questions at any time. And if you add some related to my portion, we'll cover those at the end. But at this point, I would like to invite our presenters on screen to kick off our risk adjustment implementation story, followed by a walkthrough of the implementation guide.
All right, thank you so much, Alex. So we'll give it a second for Nidhi to grab the screen. All right, great. Thank you, Nidhi. Yeah, hello, everyone, and welcome to a session on risk adjustment reporting at the point of care. I am Josh Lamb, Integration Architect with Optum. I'm here alongside Linda Michaelsen, also at Optum, but here today representing Da Vinci, and Nidhi, who is Senior Project Manager for the athenahealth payer platform. And during today's session, we're going to be discussing an implementation guide that was developed under Da Vinci, but it had been advanced through collaboration through collaborative work done by Optum and athenahealth to really advance how risk adjustment exchanges occur between payers and providers. So for those who are not aware or have a background with risk adjustments, risk adjustments is a compensation methodology that is utilized by government plans that are managed under the Affordable Care Act that helps to ensure that providers are incentivized to provide quality of care over quantity of care. So risk adjustment achieves this goal by allowing for providers to communicate the risk that is calculated based upon the conditions of the patients that a provider manages to CMS, which CMS will use to help estimate the cost of care for those populations. And the reason this helps to improve quality as opposed to the quantity of care is that when a patient has improved care outcomes, they would at least potentially utilize less care. So a provider then is kind of freed to try and make the very best decisions for his patients without being financially incentivized to do otherwise. So with that, I'll jump into the overall flow that is covered under the Da Vinci RA implementation guide. So again, the Da Vinci RA IG was designed to help support the exchange of risk adjustment reports or gaps from a payer system to a provider health system so that these gaps can be surfaced to a provider or perhaps a back office staff so that a provider can potentially utilize the data that a payer has about the patient populations to help fill in these gaps. So for example, a payer might see that a medication claim came through indicating that a condition exists, but that condition was not indicated otherwise. So that would manifest itself as a potential gap that a provider can either choose to take action on or not. So with that, I'll hand it over to Linda, who is going to share some of the great work done with Da Vinci on the development of the Da Vinci RA guide. Linda?
And Nidhi, if you could go back to that previous slide for a second. This is it just seems like such a straightforward process, right? You know, there's gaps identified, those gaps get sent to the provider, and the provider can take action on it. When Da Vinci started our work in the risk adjustment space, we knew it didn't look anything like this easy. So on the next slide, this is more probably what you see, or if you are not using the Da Vinci standard yet. You either get a bunch of spreadsheets from the payers that you work with showing what they suggest are gaps that maybe are not closed. Maybe those are historical, maybe those are suspected, or that maybe they come and sit with you and go over a report with you. Or then there's always the possibility on the far right, which is you get plethoras of stacks of paper reports. Maybe some are even electronic spreadsheets, right? So then when Da Vinci took this on the next slide, Nidhi, this was the workflow we looked at. We totally understand CMS is not the only group that uses risk adjustment for revenue, but this was a predominant player and a workflow that we could model and everyone that was working on the group could understand. So we modeled out the workflow, and it was decided in the beginning that the biggest challenge was no standard report, like we just talked about on the last screen. So on that, in that vein, we decided our first set of work needed to be around creating a standard gaps in care report that's going back and forth between the provider around risk adjustments. And so if we look at the next screen, this is what we developed, and we use a standard FHIR resource that's been there forever, by the way. This is not a new concept. It's part of the clinical reasoning module, and which was added to FHIR in DSTU2 way back then. And so we, in this measure report resource, we profiled it for what is needed for risk. And you can see on here, it shows you that when it was created, who created it, so which payer. And then we list down below under group, the code that we see as needing to be potentially addressed. The report also accounts for the fact that sometimes those are showing as closed. You get the closed gaps as well. I think the really important part, so you see the HCC code, the really important part is the evaluated resource. And on the next screen, Nidhi, if you show us, you can see that this is a resource that the payer has in their file that they can share back with the provider to let them know why they think it's a historic gap. And we show here a diagnosis code, but that resource could be anything. It could be medication, like Josh mentioned a minute ago. It could be a lab observation from blood test with a high A1C. It can be any resource that the payer has and they believe is a part of this measure report around risk adjustments or risk adjustment gaps specifically. So on the next slide, so we came up with this report, and then we started working on what we're calling STU2, and ballot 2. We're going to show you that later with more detail around this. But the part we're focused on today was actually brought to our attention by Josh and Nidhi, Athena and Optum, because they were working on a process where the reports were going to the provider, and the provider they did something at the point of care, and they wanted to let the payer know that they had taken some action. So you see on this screen that we have the query where the provider can query for the records. They can also be pushed to the provider in this workflow. And then the provider can make an annotation on that report. We'll look at that in more detail a little bit later. But this is how the workflow goes. They can add that annotation specifically into the report for a specific gap, and then that report is posted back to the payer. And we added that workflow in version 2 of our IG, and we'll look at a little more detail how that works after we go to back to Josh, who's going to tell us a little bit more about the work that was done between Athena and Optum to implement this.
All right, thank you so much for that, Linda. So yeah, as we see here, we have really what was incorporated into the Da Vinci RA implementation guide in pretty short order. So a shout out to the folks who were helping to coordinate those sessions. But what we had found, as Linda had indicated, was that we were utilizing the Da Vinci RA implementation guide, but there was an unmet need. So, and that need was where a provider, again, as Linda had alluded to, provider would receive these gap reports or these measure reports indicating that there's a gap, but there's a benefit in it being able to have a two-way type of communication. So rather than a provider sending clinical data through the FHIR interfaces, a provider or EHR systems already have existing mechanisms to provide clinical data, whether that be a clinical chart extract that they had been already delivering for some time, or through claims or other mechanisms. But they're, in addition to the existing mechanisms that providers already use today to provide clinical data feedback to the payer systems, we find great value in allowing a provider to give feedback, and perhaps they can leave a comment that says, hey, actually the gap that you saw is not accurate, and on an upcoming claim you'll see a diagnosis indicating as to why that is the case. So with that, Nidhi, we can go to the next slide and we'll dig into really the purpose that we're here today. So the reason that this topic seemed like a great thing to share with the community roundtable was it's really a live example of what this is all about. So interoperability cannot happen in a vacuum. One system that develops a standard behind closed doors and they try and leverage that with others, they're going to run into contention or perhaps repeatedly discover why the model they initially had doesn't meet all of the use cases that really exist out there in the industry. So some of the key benefits that we get from collaborating in these industry working groups, such as Da Vinci, is an ability to everyone to contribute towards the specification in an open forum, and to really reduce the myopic thinking that, or the myopic specs that might have been created if really just one or two organizations had developed a specification behind closed doors. By inviting others to the table, it allows for those things to be accounted for earlier on, and ultimately greatly reduces the amount of overall work done. So again, in very short order, Athena and Optum, we identified a need that was unmet with the current state of the implementation guide, and we were able to help drive that change and actually implement it as well. So really just trying to encourage folks to see the value there of, this stuff doesn't work without getting support from the integrator community. So with that, we'll kick it over to Nidhi, who will share what this looks like in production. Nidhi?
Thanks, Josh. So as part of Optum and athenahealth partnership, our focus has been to enrich providers' point of care experience with more meaningful patient clinical data. And we've been successful with improving this experience by implementing HL7 Da Vinci RA implementation guide. This implementation guide for point of care integrations. This IT actually gives us the ability to build payer, provider, and even model agnostic point of care integrations. Let's see what I'm talking about, right? Point of care connection is athenahealth's bidirectional data exchange capability, which enables payers to surface their members' diagnosis gaps in point of care workflows for providers to review and take appropriate actions. Let's see how this integration works. let's assume our favorite patient, Jake, has an upcoming appointment with his physician. So starting 14 days ahead, athenahealth would start requesting gaps from the payer for this member. And once those gaps are requested, the payer would send them back as they found in the system and make them available in the patient chart. These gaps are available before the appointment for the clinical staff to do any pre-appointment prep. And when Jake visits the physician on the day of the appointment, the physician gets to see the gaps in the point of care workflow, take appropriate actions, get them recorded, send them back to the payer without taking any additional steps. And in addition to that, a copy of the clinical encounter summary is also sent back to the payer as a source of evidences for those gaps. As you see here, Jake has got the care he needs. The physician has actually recorded all the information the payer needs without taking any extra steps, and the payer has received the data they're looking for. Let's moving on. How the payer's diagnosis gaps, which are for CMS HCC risk model, are surfaced in point of care workflow. As we see here, the patient's potential diagnosis and the suspected diagnosis are surfaced on the right-hand side of the patient chart. Here, all the gaps which are surfaced at the point of care are actually deduplicated and consolidated across doses so that we are minimizing the provider fatigue here. Here, the provider has the option to dismiss the gaps or accelerate the gap in the A&P workflow. As we see here, for all the suspected diagnoses, there is the placeholder to actually surface all the evidences the payer has for those diagnoses. On the left-hand side here, for CMS HCC gaps, the patient's gap and RAF scores are calculated based on their open HCC scores, open and closed HCC scores. Moving on, we are evolving today's experience to more model agnostic workspace, where the emphasis is going to be given more on clinical diagnosis rather than on condition code category. This way, the user experience is going to be shifting just not to support the risk agnostic model, which is currently very dominated with CMS HCC, but other risk models like related to ACA and Medicaid line of business. As we see here, the emphasis is given on codes, so the codes are more predominantly displayed, so the provider gets to review those data, and it's backed with the condition code category, so they also know from which condition code categories those conditions are surfaced from. Moving on, as we just saw, at the point of care integration, the providers are able to gain access to patients' critical clinical information and provide good overall patient care, rather than focusing on spending time with the clinical reps or provider relationship reps, or spending hours and hours on administrative trivia. And logging into separate portals for documentation, compiling numerous spreadsheets, or shifting to mails or snail mails. They have their time to just focus on providing care. With this, I'd like to hand it over to Linda to provide more details on the risk adjustment IG. Back to you, Linda. We can't hear you.
You're on mute.
I turned everything on but the right thing, huh? Hopefully you can see my screen.
Yes, we can see the IG.
Thank you. So I've been fortunate to be involved with the Risk Adjustment Implementation Guide since the beginning. And we started initially at one point in Da Vinci, we thought we could do quality and risk at the same time. And then we started to see there were some differences. So we separated them out into two sets of work. And we started the risk adjustment work after the DEQM work that we did in Da Vinci. When we started this work, we were really fortunate to have some business experts. that just new risk adjustment from top to bottom. And our first IG from beginning of the work group to putting it out for ballot was under a year. And that's a lot of work that goes into a very short time frame, and it could not have been done without those subject matter experts. So if you're thinking, well, I joined some of those Da Vinci work groups, but I really don't, I only have this like high level basic understanding of fire, I don't think I'd be very useful. Let me tell you, from having gone through this process with at least 4 IGs in Da Vinci, you are the capstone to making that happen. If you're not there, we don't get this workflow right. And one of the examples of that is that I mentioned earlier, we had Nidhi and Josh come to us and talk about their business need. And we were able to incorporate it into the implementation guide because we had those experts that were actually doing the implementation work join us. So this is our current version of our guide. You can see I'm at the build.fire. I think Leslie's dropping a link in if you want to follow along. But this is the current work where it stands today. We went to ballot in May, and we're resolving any changes that are being asked by the people that logged ballots or anybody who logged comments against this. We're addressing them in our work that is on that Confluence page. So we meet every Thursday at 3 o'clock Central, I think, or sorry, 3 o'clock Eastern, 2 o'clock Central. And the IG may look a little overwhelming to you because we're in this ballot phase and we want to document and show everything that we are changing to make sure people understand. And if you reviewed the first IG, that you can focus on just the points we're trying to make with this IG. So we lay out all the changes that we made, and then you're going to see these green highlights throughout. We green highlighted any text we changed from the first guide to the second guide. I only point that out because if I don't, you're going to be wondering, well, why is that in green? I don't think that's all that special. So our first guide, our first page of the guide talks through how to read the implementation guide, and then it gets into the risk adjustment process that Josh did a real high-level overview of here. And this is where our subject matter experts really made us shine. One thing we always like to talk about is this is risk adjustment for revenue normalization, not resource utilization. So it is slightly different from the risk adjustment that you would see being used in some quality measures. And then we go through and just talk about terms that we use. It's important that for my friend Viet, that we always make sure our terminology is clear, because you can't move forward if you aren't all in agreement. And sometimes the disagreements are really over the matter of terminology that is being used. So for those of you who work in risk adjustment, you probably will go through this and say, yeah, knew all that already. That's what we hope you say. If you read it and you say, I really don't think they worded that right, please let us know. Log a tracker, that's important. Our people in our industry won't understand it because you use this word and we use this word. We also lay out actors and roles. We have to discuss this early on in the IG because you can't say they, him, it, she, all those things in an IG. It just gets to be too confusing. So we lay out actors, and then we try to use those actors throughout the rest of the implementation guide so you have perspective. In this case, the client is a reporting client. We also have a remediation client. I'll talk more about those as we go on. And we have a reporting server and a remediation server. Now we start to get into more of the nitty-gritty, still very analyst, very user-friendly, but the methodology section gives you overall general guidance about how the IG is developed, what we're doing. It's like Cliff Notes version of the IG, I would say, for those of you who just need a high-level overview. And some of these pictures, you've seen similar ones, right? Here's the workflow where this particular one is about a process we call remediation, and we'll talk about that as we go on a little bit further. And then we talk about report generation. Report in this case is our risk adjustment coding gaps report, and the ways that you can generate it. I'll talk more about that in a minute. you get to see a high-level workflow, and this is done in fire resource terms. So it shows you the generation of the gap report. Here's all of our gap reports, and then there you can push them via REST query to the provider. We note also here that the provider could query using this REST query, or we could push it to their server. Different payers do it different ways, so it can be done either way. And then once the provider gets it, the workflow they may use. And again, we get into task, which is part of remediation, we'll talk about in a minute. So if they get these reports, one of the things we looked at when we first started looking at this, we were looking at it from risk being done as a back office workflow. So somebody would get these reports and then they would start to work them. And as they started to work them, they may have things that would have closed the gap. That workflow then would take them into creating that task and sending that task on back to the payer with, I don't know, maybe there's a diagnosis code that's been documented during that year. So it would close the historic gap because you do have it on record. For whatever reason, the payer didn't. Maybe the patient changed payers, maybe it didn't make it on the claim. The claim allowed for 20, but at some point it got dropped down to 12 and it was diagnosis 13 or something like that. But that's the workflow we're imagining with remediation. And I have some questions for you to think about on that workflow as we go through. So that remediation, then that task would come back, and assuming that it's a validly formatted task, it would get posted into the payer server, and then the provider could go back and query and pick up the status of that task to know that it was completed. Then the next time the provider queries for that gaps in care report, if that information truly closed the gap, then you would see now a closed gap. So that's kind of the overall workflow in this remediation process. The process we talked about today was added to address the point of care workflow, where there is something that happens at the point of care, and that the provider looks at it. He may decline the gap, saying that isn't true. He might say, I addressed the gap, and the annotation allows for that, and it also allows for some additional data to be shared back to the payer, and I'm going to show you that as well. As of the posting of this implementation guide, annotation is just an annotation. It just lets the payer know they're doing something. This is not a workflow that we defined at this point to close a gap. It is just to let, update the payer. Yes, I took action. I put it on the claim. Whatever those action codes are defined to be. By the way, we're still working on those. We put some out in the ballot. We had some comments come back, and we're looking at what those values should be, the comment code that goes back to the payer. If that sounds really interesting to you and you want to make sure your codes are listed there, join us on those Thursday calls. Then we talk a little bit about the fact you can use the attribution guide with this, just like you do with other IGs, to know which members you may want to run the queries on, or even potentially do bulk queries against the payer. That's the overview. Then we get into each of those specifics. There's a page for report generation. And we give you 3 different ways that you can potentially generate this report. So we took this example of a report for those of you who are, used to seeing something similar. We know the reports don't all look the same. If they did, then we wouldn't have to deal with this issue, right? But this is a report we sort of came up with looking at some of the reports that were being shared out there in the real world today. And then we tried to model that same workflow in our measure report. So there's the member name and date of birth, which risk model, etc. And then we show that there are these gaps, and these are this 18-1 says it's a closed gap, and the last date they got evidence was, we're imagining, this IG was published in 21, so we're imagining that it's the year 2021 for this I believe. Let me just look up here. Yeah, for this evaluation period, clinical evaluation period. So then the second one, the chronic obstructive lung disease, the evidence status is pending, which we have defined as meaning that the payer has the evidence, they just haven't gotten approval on it. And then the last one here says the major, and the supporting evidence was they have a condition of mild persistent asthma, acute exacerbation. And then the third one here is open, major depressive, bipolar, and paranoid disorder. And we say that the hierarchy was applied and this one was not superseded by other HCC codes. And then down here we have these were all historic, and these are suspected conditions. We don't get into it all in the implementation guide. What is your algorithm around suspecting? That's up to you. We're just trying to represent the data once you have created it inside the reporting. So here is our suspected condition of morbid obesity. This is actually a closed gap because we did get data on it. We sent it out as suspected, but we got back evidence on it. Cystic fibrosis is still an open gap, and based on something, in our little sample here, we don't have any supporting evidence for it. Ideally, it would be nice there to have a supporting evidence of something like a medication that's prescribed for cystic fibrosis, right? And then we took that into what that might look like in the FHIR resources. So our measure report is actually a bundle. Our risk adjustment coding gap report is actually a bundle, and it consists of risk adjustment coding gap reports. And these are FHIR measure report resources. If you know those, perhaps you work in quality. It's just the same resource, just we profiled it differently to be used for risk adjustments. And then we point to a measure. In this case, our measure is our model. So the example we have here is CMS's model HCCV24. So what that means is you're going to get a measure report for each patient for each model. So you would get a measure report, for example, if you were doing, if you had the RX HCCs for CMS, you would get a separate report. That report, of course, reports to the patient and the organization that sent out the report, so the payer. And then for every HCC, we repeat in the measure report the group. And inside that group, we have data elements that show what the code is, what for the HCC code, is it a historic or suspected or gap or net new. You know, we could just have something that we think this is a net new. They didn't gap. Most of the time when you get a net new, it's going to be closed because we saw something on a claim that open and closed a gap. So it's net new and it's closed. So and then we also have whether it's open, closed, or pending. And then if hierarchy is used, HCC does, there's options to say if that hierarchy was superseded or not. In this report, you can send all of the HCC codes. You don't have to apply the hierarchy. We found out from most of the people that were joining the calls that payers don't typically do that. You know, they want to get just the important gaps in front of the provider. So they wouldn't send all those that were superseded, but you could. And then each of these gaps points or can point to evaluated resources, one or more, that the payer has that led them to put this on the gap report. You know, the historic might be a condition from the prior year that they was documented and they believe didn't go away or probably didn't go away, and that they are calling it a historic gap. We had this diagnosis from last year. We, you know, think it's probably a gap you need to close this year. And like I mentioned, it can point to one to many. One of the things that we point out is you only have to include the encounter once. It can be referenced by more than one of these HCC gaps. So you're not getting that same, you're not getting a heavyweight set of data when this comes through. Down here for generating that report, there are 3 options. There's one that just takes a CSV file, and you can take this CSV and generate. Here's an example of what it would look like. You would post it to your function that converts the CSV data to a measure or a bundle with the measure reports in it. In this option, the way we've defined it, just our base definition up here, we didn't allow for attaching evaluated resources, because that's a really hard thing to do inside of a spreadsheet. But of course, you could do that inside of a CSV. The second way of doing it is maybe you, let's get down there to it, maybe you natively understand how to create those FHIR resources. So you can create that right out of your, the payer can generate it right out of their system, where they track all of the risk adjustment codes for the members in their plans. And then the third one is an evaluated approach. I'm going to talk more about that towards the end here, but this is the way that goes very similar to what is done in quality right now. It can use CQL to generate a gaps in care report, as clinical quality language. And then we move on, and we have pages that talk in detail about how to do the report query, which the report query is a pretty straightforward process. You're just doing a base query, no special operation required. And that was a change we made in this implementation guide. And then here is our report annotation, a whole page on what Josh and Nidhi are doing here. And it shows you the workflow that they use, where they generated the report. It goes to the provider system, the provider displays that report, the provider annotates, and then it comes back to the payer. So let me show you, for those FHIR profile people among you, we have profiled that we have a risk adjustment bundle, and then we have our measure report, and that's sort of the meat of the matter, I guess. And so if you look down here on the measure report, and I always like to look at snapshot because I forget I'm not looking at snapshot and I can't find things. But you see the things we talked about earlier. There's the measure that you point to. So that's the CMS HCC model. Who's the patient? Who's the reporter, the organization that generated this report? And for what period of time is it for? And then we get into groups repeat, and we have those elements we were talking about, the suspect type. So is it historic, suspected, or is it a net new? The evidence status, is it open, closed, or pending? The status date. If you're using hierarchy, and by the way, one of the options is that you're not using hierarchy, right? So you can either say superseded, applied superseded, or not applied or not applicable. There's a confidence code in here. We really would appreciate feedback on this too. Let me open this real quick. I think you can probably see this screen, but on our confidence, we came up with a set of codes that I think it's a 4-level set of codes, and I probably clicked on the wrong thing. Oh no, for the extension, and let me get to the code value set here. Are these confidence codes that make sense to you? Are low, medium, high, very high? Or would you do something different? We look to the experts. There seemed to be no great consistency in how that would be reported, but it would be nice to have. And then we get into annotation. And annotation is what the workflow today works off of that we showed you. And annotation is an extension we added to the measure report. It's a complex extension, meaning it has several elements. So the extension, the annotation allows you to say who annotated. It allows you to say when it was annotated. So, Dr. Smith, and on a certain date and time when he saw the patient. There's a place for text, and there's a place for a code. And the code that we have added here are annotation codes. Again, another topic we're discussing, and we'd love to have some feedback here. These are the ones we went out with: assess present, assess not present, in progress, deferred, or not assessed. And we're talking about those now. We think maybe there's some value in adding some detail to those codes, or a few different codes that we add here. So please join us. Love your information or perspective on that. What would be useful for the payer to receive back? And then in addition to that, there's related data identifiers. So we imagined, and not really so much imagination, that there'd be systems like Athena that could give us a claim ID back. And so they could put in here that the claim identifier is whatever, and send it back. And then when the payer gets that, they know they're waiting on the claim, and the claim in the provider believes the claim will close that gap. We also have a section where you can put in related data, and you can reference any resources that you want to include here and send back as an annotation. We're having some discussion around this. Please join us. Could that related data actually serve at some point in the future to close a gap? And much discussion there. I won't say yes or no on that. We really are just beginning the discussion around whether we could change annotation from just being an annotation to going back to being something where it actually could close the gap by attaching data here. So that's our, that is the measure report. You see in our fire artifacts, we have a number of other profiles around patient group and task. I wanted to talk a little bit about task and get some feedback on that, or you to think about it and come potentially to our work group and talk about it. We have this remediation workflow, and until our friends that joined us on the call today told us about the annotation, we had imagined that this was back office activity, that when a report came to a provider, that they would have office people that were working it. And when they get the get the report, they might have data that they want to send back via a task, and this is a remediation server. And the remediation server, the task would go to them. There would be a risk adjustment coder who might, look at that task and accept it into the system, and or post it into the system potentially, whatever the workflow is, and then that would update the payer's system. So the next time they queried, that gap could potentially be closed. We haven't had many people say to us that they'd use this workflow. So we'd really like some feedback. If you think that this workflow would be used to close risk adjustment gaps, as opposed to the annotation workflow we talked about earlier, we really would welcome you to join us, read through this page, and tell us if it makes sense, does it make sense, how you'd change it to meet the needs of your organization. Last but certainly not least, I want to talk about where we think we're going. We think we are going to digital condition categories. Now that DCC there might look slightly familiar to you if you live in the quality world. And I find a lot of people that live in the risk world also live in the quality world. So you may have seen digital quality measures, right, that are used in quality. And in quality, those use what's called CQL and fire resources or fire elements, and they can look at, you define the CQL, it says if the patient has this and it occurred, it was during an encounter on this date and whatever, that meets that, we need that data, and that's what closes our quality gap. So this uses that same premise, and we just started defining it. We showed it for the first time at the CMS Connectathon last year. And we talked about the same premise as a quality measure. You have an initial population. And then in here, we have an example of a very simple, although we understand this is risk code is probably going away. But the idea was 189 is an amputated toe over here, acquired absence of fingers and toes. And we represented a way with CQL that we showed that during, it looked for an encounter where someone had documented this diagnosis. And we made a note that exclusions would be any congenital absence of the same thing. Just the beginning work on here. And we realized that this is just the diagnoses. We understand in risk and quality, there's also the meet and tamper standards to show that the provider addressed it in some way. With this, we think, that might be an assessment or, of the CHO in some way. And we're starting to think about how this could be codified, because we know there's a lot of objective, subjective is maybe the better word, opinions about data, especially around the meet and tamper standards and what truly addresses it and shows that the gap was closed, not just that they had the diagnoses documented, but there was actually medication given, that something was evaluated, lab work, or imaging or whatever was done to actually prove that they were addressing the issue and taking care of the patient, like Josh mentioned, to keep them these issues that cause the need for extra care to be well managed. We'd love your feedback on this as well. We're just beginning our discussion around this. We are thinking that maybe we'll explore this more as we move after we publish our changes to this ballot. Maybe we'll take that on, think more about it in our next iteration, especially if there's interest in it. And we really welcome your thoughts, because we feel just like it's sort of full circle here, right? We started out thinking that quality and risk were very close. The more we work with them, the more we think they're associated. So we'd really like your input on all of this. I will tell you that the IG has the very same things every other IG does. We have examples, so you can go in here and see exactly how a resource looks. And an example, and I don't know about you, but for me, an example, if I'm trying to figure out what do they mean, I can look at an example and it makes a lot more sense to me. So there are examples in this guide. We have a glossary because, again, back to my friend Viet, we want to make sure we're all talking the same terms. So if you see a word here, again, especially appreciate feedback on these glossaries. And if you say, geez, that's really not the term that you're going to appeal to the risk adjustment coders with, let us know. We really appreciate input of any sort. I will finish with reminding everybody, every page in every IG has a propose a change. Even if you can't show up to our work groups, you can click on this button and propose a change to a word, a misspelling. All of those things are useful. So please do look through the guide. Think about how it affects you, if it can meet your needs. If it doesn't quite meet your needs, that's even more reason to join us on our Thursday calls. And it's really exciting to see what, and by the way, Josh worked on most of this work before he and I even connected, knowing that Da Vinci was involved and that I was involved in the Da Vinci IG, but that Optum and Athena were able to work on this, read the guide, and get them to the place they are today, which is presenting these risk adjustments at the point of care where they can best be addressed. And with that, Alex, I am going to hand it back.
Thank you. I appreciate that. I'm going to invite everybody on screen. I want to make sure I'm showing the question box for everyone. I'm going to ask you a few questions. I think, Josh, I'd like to kick off with you, sort of linking the beginning of the conversation and the overview of the work that Optum and athenahealth have undertaken to bring this implementation guide to fruition. So I want to ask you first, is it in production? And what version of the implementation guide are you using?
Yes, happy to say we are in production. As a matter of fact, in a pretty short order, both Athena and Optum were able to leverage the work done on the implementation guide with others. So on the Optum side, we were able to implement this with another payer organization, or I'm sorry, another provider organization, and similar for Athena. So really driving back to the value of the value in terms of how you can scale these things once you contribute in these open forums and really get things in an open specification. And for your second question, Alex.
I was curious because we saw an implementation guide where Linda's really calling for a lot of feedback, but I wondered which version of the implementation guide that you've actually implemented.
So this is where things get a little more interesting. So when you are an early implementer or you're contributing towards a spec, at the point that you take the judgment call that, hey, the things that we proposed or the things that we're doing today, everyone was in agreement that that's going to get codified in the spec. That's we were actually implementing it a little bit prior to it going through the full process. So a little bit ahead. So early, we were a little bit early on. I believe it was the second ballot version of this implementation guide.
Yeah, well, that's because you had the confidence, you knew what it was saying, you knew what it needed to do, and you could transform that implementation guide specification into software code. And what I think is really phenomenal is to hear that you've not only deployed it, but you're actually now starting you're starting to scale it to other ones. And so I'd like to talk a little bit about that point of care experience and the value that you're seeing from your provider users and your payer users as to feedbacks that you've gotten from them, either about their ability, the ease of use or the communication efficiencies or being able to put staff into other areas. So any commentary from the presenters on that, the actual experience of having this in a production environment?
Sure, Alex, I can take that one. So as I was mentioning in the session earlier, that of course with this IG, we've been able to implement payer agnostic point of care integration. What does that actually mean is that in absence of this integration, the payers were having direct integration with providers. So a big provider may have like 5 integration, one for each payer, where they have to like juggle between these smart apps and try to manage their patients' diagnosis gaps. But with this integration, what we've been able to do in our product is create a native seamless integration where, irrespective of which payer the data is coming from, provider has a consistent experience. So that way, they don't have to juggle between multiple screens. So the fatigue is definitely coming, minimizing there. And also, they've been able to take quick action. So the way we kind of measure the success of our integration is with our gap action rate. And where we started with the baseline, which was like early 20-25%, we see this year it's gone way up from 40 to 60% across payers. So that way we see the turnaround time on, I wouldn't say turnaround time, but I would just say gap action rates. That means how many gaps are actually acted on or addressed by the provider has improved drastically when compared to the baseline from previous years.
That's exciting, because when you really think about the fact, like from a patient perspective, they probably don't know anything about a risk adjustment system behind the scenes, but that the provider-patient interaction, that the providers got better data at their fingertips and can interact and close those gaps. So I don't know about this, but I'm getting better healthcare outcome potential because those gaps are being identified. That's what this is all about. We're getting to that quality outcomes, not necessarily quantity outcome. And Josh, I think you wanted to say something.
Yeah, I completely echo all of Nidhi's points there. And really, you asked about some of the feedback we received, and I'll say that the 2 main types of feedback we've gotten from our providers who are implementing this alongside us is, one, they really do enjoy having a payer agnostic experience. Now, that might be counterintuitive. If you're building a service for a payer, you're like, well, I want them to have all the special bells and whistles that only I can offer as the payer. But as it turns out, if you want to increase utilization, not having 300 different experiences for a provider who's trying to focus on quality of care and on patient care, not having that provider have to focus on the nuance or whatever's different about each payer, and having all that be standardized is really a great value. So providers do tend to engage more heavily in with the the service offerings from a payer that align with a standard. And in terms of the second feedback, it really touches on some of the things that Linda is at least indicated that she's suspecting is the case, where she had mentioned there's really more similar between the different types of measure reports across quality and risk than there is differences. And that was some of the main feedback we gotten from implementers, where they're like, hey, I like how this aligns with a standard that I can go and leverage with others. Why can't we do this for our quality gaps? So let's leverage that same type of approach for our quality gaps. So that's some future work that we're eager to help contribute and help foster as well. Again, really multiplying the effort there, where we're able to not only scale this out with different payers and providers, but also scale this approach out for different types of measure reports or gaps.
Well, we're getting a question about the link to the recording. So Leslie, maybe you could post for us the link into the chat for folks to get to the video recording page. I plan to load these tomorrow, but I think it's just another indication from today's attendees that this is excellent information and they're really benefiting from you sharing the story. And I think it's really interesting to see this idea that industry participants from different parts of the ecosystem can come together, create a design that can then be put into software that becomes integrated at that point of care experience for the providers, so that they don't have to worry about the nits and the gnats when they're seeing patient Jake or my favorite patient Susie Q, and being able to say, what do I need to do for Susie Q? And think about, what does this payer want versus that payer want? That's all taken care of in the back end system, so that when they're in workflow, they're just seeing, oh, Jake or Susie Q needs to have this, or I need to focus on that. And then all of a sudden that translates into better care, more efficient use of staff, and less frustration and friction between the provider and the payer when they're all trying to focus around taking care of Jake and Susie Q. That's sort of how I'm looking at all of this. One thing I did want to tie into was this aspect that Linda's tipped us into, was this quality and risk implementation guide similarities. And what I really want to focus on here, Linda, and maybe Josh and Nidhi, you have commentary on this as well, is this idea of FHIR capabilities, resources, profiles, extensions. Even if they're similar but different, there's still, you're learning how to do one, and you can apply that implementation guide experience and infrastructure setup and software coding integration to the other. So instead of just, I know you may want to talk about some of the digital condition code similarity aspects, but this idea of, you've taken a journey in quality, or you've taken a journey in attribution, or you've taken a journey in risk adjustment, there seems to me like you're getting a bang for the buck across the use of an implementation guide in one place, because it makes you all that better ready to launch another implementation guide. And we've heard from athenahealth folks last month, they presented as well. And I'm just curious from the presenters today, what's your experience on not only you're talking about payer scalability, but your own internal scalability?
Well, I can jump in. I'll say I'm primarily on the implementation front, and I'll say interoperability is hard. When you're starting off, at least, it can be very hard getting everyone to talk the same language, and being able to leverage and reuse assets is really the goal here. That's if we distill all this down, that's what we're driving towards. So if you want to scale software, you can put more effort into the code that is serving 100 use cases than you can the code that's serving one use case. The code that is touching 50 million patients, that code is more valuable than the code that touches a few thousand patients. So the reuse is really the ultimate goal here. And getting to that point is, at first, when something's brand new, you're absolutely right, Alex. It's not as easy to get that first one, but the subsequent ones are certainly, it certainly becomes more easier as you implement.
And you make me really think of Linda's comment about we need the experts who are living the workflow today to come to the conversation so that the specification really reflects the best and brightest of thinking, so that when we start to implement it, we can learn and apply, but also that creates that bookend to your goal of scalability. Linda, Nidhi, would you like to weigh in here? Oh, you're on mute.
I don't know how I did that. I agree 100%. And I think Josh mentioned two things that I think are pretty interesting here. I mentioned about the digital condition categories and, modeling that part of it, the ability to evaluate the measures or the gaps and the measures in a similar way and making it more objective instead of subjective. That's an important part. The other part that Josh mentioned was, and I've logged a tracker, and I'll be dragging my friends Nidhi and Josh with me into the next work on DEQM, because they are looking at that measure report and saying, why can't we have the annotation on a measure report the same way we do for risk, for quality? Because point of care, we want to present it. And I would argue there's additional things, and I know Josh and Nidhi know this too. Payer presents a lot of useful information to the provider, such as medication adherence, risk for falls. You can, if you go out and query on pick a payer of your choice and health report card or health scorecard or something, they all do similar things to this to help provide to give the provider data. Obviously, you don't want to overburden, but if we can make the ability to share this data similar and all using a measure report with different groups and categories in it and an annotation for the response back, it's made it simpler for the payer to share the data, for the consuming EMR to show it to the provider, and for the provider to see a consistent workflow, whether he's dealing with 15 or 100 payers.
It shortens that implementation timeline drastically as well. So my selfish goal there is less work, a lot less work, I'll say.
Just want to add on some thoughts from my end as well here. So I totally echo what Josh and Linda has been saying. And as athenahealth, when we are contributing in these Da Vinci forums, our main focus has been how much we can repurpose whatever the IGs we are doing and how much of these can be cross-consume across use cases, so that the overhead at the implementation end is really minimal, right? That's when, in true sense, the IG can be adopted by more and more implementers, right? So that's the goal and focus, and we want to definitely be able to contribute here and share our experience so that we can influence that, right? Reusability and repeatability. Yeah, those are the two words I would like to call out here. Yeah.
And as a patient, I appreciate it because it makes sure that I'm getting the best care possible and we're using our resources the best we can. So,
and I think that's all our focus. We talk about that all the time. I mean, that's the whole reason for risk adjustment. Obviously, the payer wants it because they want to be receive the monies to take care of the patient with the risk that they have. But ultimately, it's all focused on getting that care to the patient, right? And to make sure that even patients with serious illness that has risk, high risk scores, are taken by providers and payers, and that they're given the best care that is needed for that. So I think all of us focus on patients. Sometimes we get into the details of the logistics, but I know the three of us are patient focused because we've talked about it before.
No, we're all a fiery group in these working sessions, so definitely agree there. And Nidhi?
Yeah, I was just saying, end of the day, it's better patient clinical outcomes. That's the goal. Yeah.
Well, we're on a journey as a nation for quality outcomes, transforming from fee-for-service, quantity-oriented, and Da Vinci has really been leading the charge on that. I think it's an innovative project because it recognized the power of standards as we had seen the nation go through the transformation under HIPAA-era regulations and then further advance towards document sharing under the meaningful use high-tech days. And now that we're in the 21st century, it's really great to see modern API technologies come into the forefront, and that the industry is leading the charge in figuring out how to build standards that all can use to support scalability and efficiency while still competing in the marketplace, all to the benefit of the patients. So with that, I'm going to thank our presenters for the fantastic presentation today and look forward to seeing everybody at our next community roundtable, August 23rd, because you all get to have some vacation time, hopefully in July. I know I will, and look forward to seeing you at the end of August. And we will get the information details about that event out later next month. In the meantime, we will post the slides and the recording tomorrow morning. So with that, have a great evening, everybody.
Thank you for having us.
All right, yeah, thank you all.